magical slides in there, Sarah, to read for everybody.
Can you see them okay?
Yeah.
Okay.
Let's see the PowerPoint window. Okay, it's in presenter view, but it's all good. So welcome everyone to our Cannabis Research Review Board meeting. We're holding this meeting virtually and hosted by DHHS and the Center for Medical Cannabis in Salt Lake. And public notice of this meeting was provided as required and posted on the public notice website. Our purpose is to review the available research literature and assist DHHS and Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for treatment of certain medical conditions identified as qualifying medical conditions. The meeting is being recorded. Recording of this meeting will be posted to the public notice website within 3 business days following the date of this meeting. We'll also have some minutes prepared for the meeting, and those approved minutes will be posted to the public notice website within 3 days as well after being approved. Here are our board members, and I think we've got everyone. Did we get everyone signed on now? Yep, and there's Misty too. And then we've got Rich and Sarah and Lauren too. So we're all here. Awesome. At the end, we will have a public comment period. And I guess I can go over that again once we get to the public comment period, but we'll ask anyone with public comments to hold those to the end unless the board has someone to call on for something else in between. And we'll go back over some of those little rules. Okay. All right. Thank you, Sarah. Let's take a look at our minutes from last quarter. We've got these up there. If anyone has anything that they wanted to bring up, go ahead. Otherwise, I guess we can scroll through really quick to check on things. We had a very busy meeting last time, huh? We got through all kinds of stuff. Okay. All right. Anyone have any edits or revisions to those minutes? If not, I'd take a motion to approve.
I'd move to approve.
And I'll second that.
All in favor of approving the minutes from last meeting? All right, unanimous there. Thank you, everybody. Okay, and right on schedule, we have Russ to kind of take us through some of the revisions. I've seen lots of busy edits in there from Melissa and everyone else that I think everyone was feeling pretty good about, but let's take a look to see what else is in there and maybe highlight any of the
newest
changes.
The newest ones are from Taylor. I looked at Melissa's a couple days ago and they look great. I haven't looked at all of Taylor's, but it looks like a lot of them are just you know, wording edits. Though I guess the one I would want to ask more about would be this first one about the this yellow box here. And Taylor, you can speak to this if you wish, but basically separating out the evidence box into 2 sections, I guess. Is that what you're saying?
Yeah, as I was reading through it, it kind of caught me by surprise that the evidence statement was down in there. It sort of kind of looks like a disclaimer box, and the first part reads that way, but then kind of like where the evidence is, or you know, how we're summarizing the evidence for this report is in that box. So I wouldn't have expected it to be there, but so it's just a thought.
Well, I'll add to that. I kind of like the idea, Taylor, of making this a little bit more aesthetically pleasing
Yeah,
Sarah had mentioned in her email that some of our documents have a different format. One has a disclaimer before and one has a disclaimer after. And after looking at that, Sarah, one of them that's before isn't even a disclaimer, it's just a definition. I think it was the chronic pain one. It says disclaimer, but it's really a definition. So I like the idea, Taylor, of let's format it so it looks good. The whole point of a colored box is to draw attention to it.
right.
And so it is aesthetics. And so why not separate them if they do have different purposes, one being a disclaimer and one being a summary of our evidence. So I like the
So
idea of
this,
reformatting.
so the summary first and then the disclaimer following, or vice versa?
I think disclaimers should be after. I mean,
Yeah,
the
that's kind of
title of the
my,
document, I mean, disclaimer is important, but it's not the most important. I
right.
don't think it should be first.
Okay, I agree with that. Yeah,
And in whatever way we choose to go, I think, across all of our reference guidance documents, if the format's the same, so if they see a box in the same place, it says the same information for that topic each time, so that when someone's reviewing it, they can look in the same place and be like, okay, I know where to find the evidence summary because it's always in this box in this place on this document.
Totally agree.
yeah, I do too. And I like a summary coming first because it kind of gives you an overview of what this is about, but the disclaimer can come later.
That's what you're going there for, right?
Yeah,
Yeah.
exactly. Exactly.
So really, language is good, and we're in agreement with that, but it'd be reformatting because this makes it look like the entire box is about a warning, and then you don't realize that the whole meat of the paper is also right there in there, and you
Yeah.
can like skip over it and
Right.
not recognize that it's there. And you can
Right.
almost say, and then there's the smoking thing right under that that's in a different format that's also kind of a warning that's, I guess, more about the law rather than, what to do with dosing, but maybe those two things could go together and just make sure that it's like, here's our overarching statement. Also, please be aware of these couple of caveats for any patient using medical cannabis.
Yeah, that would be better for sure.
How do we want to handle that, like reformatting and styling and voting then? We could do a tentative approval on, we will change that, and then a thumbs up on whatever color choice or
Yeah.
box style we pick.
Yeah, I think that's perfect, Mike. Just let's have someone with the best eye for detail play around with it. But I think we're in agreement that we should reformat it with a consistent format.
Yeah.
And Sarah can just circle back and put something together and present it to the
Yeah.
group for
Yeah, I'm happy to
design.
do that.
Yeah.
Yeah. Sounds good.
Russ, the only other thing I might draw attention to, and as I went through it, is I thought the evidence summary was great. There's a lot of text there, and it is kind of broken down by study. And so I wondered if it would lend itself to putting some kind of a table in here.
Yeah, I saw that comment.
Yeah.
Yeah, I think the table might bring some clarity to that. I think I agree with that. Because otherwise you're reading a bunch of text, you know. So what, summarize the study itself in a table format and leave a lot of the text out is what you're saying?
Yeah, so I mean, like, I think you can leave the text as is, but even like Lauren does in some of her presentations, or even when you read in like an article on Up to Date, there's often, or even if you read a review paper that's reviewing a bunch of different individual studies, they'll have like the studies listed out in one column,
Right.
and like, the evidence or key findings in another column,
Yeah.
and some limitations in another column, and like the study design in another column, so you can like just kind of get a flavor for like, okay,
Okay.
this is the
No, I
landscape.
like that. So
Yeah.
column-oriented table. Yeah, that sounds good to me too.
Another benefit to that, Taylor and Russ, is that think about the future. If we readdress this in another year or two, or if a new study comes out, a table is an easy way to, well, let's take out the worst one and put in this new one. And then it's easy to update
Right.
because we've got better data as it comes along. And so we shouldn't think about too much of the future, but it really makes it nice when the format is amenable to updating.
Yeah.
Lauren
also
has
think-
in her documents a table already that she sent to us. So we could potentially just use what Lauren has created.
Yeah. For this specific one, or just use the table format that she uses?
She has a table format for all the,
For all the studies?
yeah,
Yeah.
Lauren, you can chime in, but I remember seeing it.
Yeah, in the full written report, there's always a table of the studies at the end. Although it's kind of large, a little clunky. I don't know if that's quite what you want in the like. It might be if you look at the presentation, it might be shorter. You could maybe use that.
I think we could take your table and I mean, we might synthesize some of the ideas expressed in each cell just to, reduce the amount of text,
Yeah.
and keep the detail in like the actual, script of the document. But yeah, I think we could really just go there. I mean, you've done the work already, so.
Yeah, that was what I was alluding to, Taylor, was kind of just in the table, just a real quick summary, and then the detail can be in the body of the text.
I agree, that's great.
I'm just looking through if there's anything else that stands out. Yeah, I do like the fact that we refocus, especially Melissa made the point of this of putting psychotherapy kind of for the primary for PTSD and using cannabinoids as the adjunctive therapy. And the studies kind of lended to that, not that they were that great or that strong, but cannabis didn't seem to be a primary therapy recommendation in anything I was reading here. The rest of it looked good to me. Any other remarks or comments?
Also, let me know if I'm scrolling too fast or need to slow down or anything. It
No.
just, there's a lot of info in here.
I know, Sarah, you made a comment on uncertain how to cite in the reference section. Is that, not seeing that. Where is that? Oh, I see what you're talking about there. No, I mean, it looks pretty good to me. Anything else? Anyone else see?
I think it looks great, and I appreciate everyone's comments and
Yeah.
edits. They're very thoughtful.
Yeah, no, I really appreciate the input, especially Taylor's remarks and Melissa's edits earlier. I put some comments in last time, but I think we incorporated my suggestions already. I think we should just work on the formatting and that table, and I think we've got a document that we can maybe approve and release next meeting.
Sure. Yeah, I was thinking I could just I can help with the editing and formatting and stuff and send it back when I send out my email blast
Okay.
and get everyone's thoughts.
Okay, good. I like that.
But if everyone's okay with the suggested changes, I'll just accept those after this meeting.
Yeah,
I
and
am.
then
Yeah.
yep. And I think, Sarah, if as we talked about the aesthetics of the boxes and everything, if we make this document sort of the pilot of that reformatting, then we'll have to readdress all of our documents and change them to be consistent format. It
Mhm.
wouldn't be changing the content, just the formatting. So it'd be easy to approve those in a meeting, but it would be like 10 or 12 documents.
Yeah.
Yeah. Yeah, I do think there's value to that, especially because if our goal is to have people using these documents, they are very lengthy. So I think having
Yeah.
things broken out that way will be a lot easier for people to
Yeah.
read, and maybe more people will read them.
Because
Well,
a lot
that's
of
why I
people
like.
skim.
Yeah.
They're,
That's why it's good to have both the boxes, and then I like Taylor's suggestion of the table, because then they don't have to read the whole thing to get an idea of what it's about and what the evidence supporting it is.
Is there a way to hyperlink from the table to the actual text that goes into it further? Is there a way to do that? If people want to read more about it, they just click it, it takes you further in the document.
I can mess around with that. I'm not positive if that's a potential in Google Docs, but I'll see and let you guys know.
Okay. Yeah. All right. I like it. I think that's the plan.
And some of you may have seen a comment. Michael, you may have seen this from Nanette. She just posted
Yeah, I just
comment.
saw
Yeah.
that and see if Russ, you wanted to address. I think probably good to address that now while we're talking about that. Nanette, do you want to elaborate or point to like what the spot is? I know we got a long document here and which section that was in that says side effect versus adverse effect versus whichever.
Yeah, it looks like it's used in that yellow box. And then there's likely a few other cases of side effects using that term.
Yeah.
That's a
Is that
good point about language. Side effects just suggest that it was an effect separate from its primary intended effect. But what we really want to know, but we have oodles of examples of medicines that we've created for one thing, but they're better. Their side effect was better than the initial intent, right? I mean, there are dozens of examples of that. So adverse effect is a more proper term. It's an undesirable effect. So I like the idea of maybe standardize some of our language.
Yeah.
Or off-target effect.
Yeah, I think adverse, because off target to me says the same as side, as it's
Yeah.
different
Yeah.
from something. And
I
this
think
is something that is then undesirable, whatever
Yeah.
the effect happens to
Yeah. I agree.
be that would cause someone to reduce a dose or discontinue.
Yeah, if
medication.
you're,
I guess that goes to like, where else is this language throughout all of our documents? Is probably good. And I'm sure we probably even say adverse effects in the rest of this document too, because I think
Yeah,
that's
I
the
was gonna
language
say-
we're used to using anyway. And
Yeah.
then probably have just skimmed over the
So-
fact that it says side effects in this sort of
Do a find
box that's carried around.
and change on that phrase.
Yeah, I'm sure it's all over the place on the website and other documents.
Yeah.
It says adverse in other places.
Yeah.
Probably says non-target effect somewhere else too.
You have to remember too, adverse is still somewhat a subjective term. It depends upon how the
Exactly.
patient's interpreting it.
And Taylor, I'd still go with just adverse effects, because not all adverse effects of cannabis necessarily have to be psychoactive of orthostatic hypotension, or if we were
Agree.
thinking about a
Agree.
drug interaction in a different circumstance, or then a withdrawal phenomenon or a use disorder issue, that is all necessarily psychoactive. And I think adverse effects would leave it like very broad.
I totally agree.
The other thing about psychoactive is any compound, food, edible, medicine that creates a change in consciousness or shift in mood is psychoactive. If you mean psychotropic, then we're talking about a different animal. I think we should be clear about that as well.
all right? Anything else with this document before we go back to the agenda?
I don't have anything else.
Okay, sounds like not necessarily taking a vote because we got a few more things to do as far
Fix.
as the table and the reformatting and a little bit of
Right.
language tweaks here and there.
Right.
Okay, the overall no disagreement with our bottom line summary statement about the level of evidence and the recommendation we're making. It sounds like we're all good to go there. Okay, anything else on that, Russ or anybody else?
No, I think the edits will make a big difference, and we can look at approval next meeting.
Okay, sounds excellent. And I guess we go ahead and schedule over to Lauren for the next topic and possibly, well, I'll hold till Rich goes after that. Our next topic anyway, in sequence.
All right. Let me just share my slides. Hopefully you're seeing that. All right. So, hi everyone. I'm Lauren. I'm a pharmacist consultant to the Center for Medical Cannabis, and today's presentation is an overview of experimental evidence for the use of cannabis-related products in people living with epilepsy. The purpose of this review is to summarize experimental controlled trial evidence for the use of cannabis or cannabinoid-based products, abbreviated CBPs, in people with epilepsy to assist the CRRB in updating guidance. I searched for systematic reviews of experimental controlled trials, abbreviated ECTs, including randomized or non-randomized trials published since 2018. I included ECTs of any design that included participants with epilepsy and that administered a natural or synthetic CBP for any duration with any outcome. I excluded trials only published as an abstract that lacked a comparator group, only reported secondary after the fact results, or that reported insufficient research standards. I summarized primary efficacy and safety results from included trials and extracted risk of bias ratings for the included trials from systematic reviews when they were available. Overall, I identified 15 ECTs of CBPs in people with epilepsy, and I included 11 of those trials. 4 older trials that each evaluated oral CBD were excluded because they lacked information about the protection of human subjects and/or, in my opinion, lacked sufficient reporting of methods and results to reliably assess efficacy or safety. You can refer to Appendix A of the full written report for details about those excluded trials. 11 randomized controlled trials, abbreviated RCTs, were included. 8 of the 11 trials evaluated the use of the FDA-approved CBD oral solution, Epidiolex, including 5 trials among patients with the FDA-approved indications for Epidiolex, the rare syndromes Dravet syndrome and Lennox-Gastaut syndrome, as well as tuberous sclerosis complex. And 2 other trials evaluated drug-drug interactions, abbreviated DDIs, with Epidiolex, and 3 additional RCTs address a different oral CBD formulation, transdermal CBD or oral cannabivarin, for the treatment of adults with focal epilepsy. Of the 11 included RCTs, 3 RCTs are addressed by the current CRRB guidance. All 11 RCTs were parallel group, double-blinded, and placebo-controlled and were published between 2017 and 2023. In each trial, the studied cannabinoid was administered as an adjunct to other anti-seizure therapies, potentially including anti-seizure drugs, dietary modifications, or neuromodulatory therapies like vagus nerve stimulation. In the 8 efficacy-focused RCTs, efficacy of the studied cannabinoid was assessed after treatment for 8 to 16 weeks, and the safety or DDI-focused trials were shorter with treatment durations of about 3 to 4 weeks. Approximately 1,400 total participants were included in the 11 trials, of whom about 62% were randomized to the studied cannabinoid. In general, particularly in the efficacy-focused trials, included participants were considered drug-resistant or treatment refractory with persistent seizures despite ongoing treatment with anti-seizure drugs, abbreviated ASDs. The ages of included participants varied. Generally, even in the 8 trials that allowed adult participation, patients tended to be relatively young with an average or median ages of 40 years old or younger. Generally, when reported, trials enrolled participants lacking significant non-epileptic comorbidities, including those with significant hepatic impairment, a history of alcohol or substance use disorders, or significant suicidality at baseline. Trials did not report details about prior cannabis or cannabinoid treatment by participants. It seems that many trials excluded participants with recent use in the prior month or 3 months, although some trials may have allowed participants with recent cannabis use if they agreed to abstain during the trial. 2 efficacy-focused RCTs studied Epidiolex in about 120 to 200 children or adolescents with confirmed Dravet syndrome, abbreviated DS, who had drug-resistant seizures or insufficient seizure control despite 1 or more ASD. Participants were required to have at least 4 convulsive seizures over the monitored 4-week baseline period, which included tonic-clonic, tonic-clonic, and atonic seizures. Seizures were tracked by caregivers. In aggregate, by randomized therapy, the median number of convulsive seizures per month was between 9 and 17 at baseline. Participants were allowed to continue other anti-seizure therapies during the trial if they had been taking the therapy for at least 4 weeks and usage would remain stable during the trial. However, participants who had been taking the ASD felbamate for less than 1 year were excluded from participation. The third trial in children with DS was smaller and shorter than the 2 efficacy-focused trials. 34 participants were enrolled with insufficient seizure control with 4 or less convulsive seizures during the 4-week baseline period, and this trial focused on the pharmacokinetics of Epidiolex and safety outcomes. On this slide and on future slides with efficacy results, I bolded and highlighted statistically significant results in green, whereas non-significant results are highlighted in gray. And for the purposes of the summary, I focus on reporting the primary and some key secondary outcome results, although there's many other results that are reported in the full studies. The trials by Davinsky et al. And Miller et al. Both met their primary efficacy outcome, finding that CBD as Epidiolex 10 or 20 milligrams per kilograms per day for 14 weeks significantly reduced convulsive seizure frequency from baseline as compared to matched placebo. Most pre-specified key secondary efficacy outcomes also favored both CBD dosages over placebo. The percentage of participants achieving at least a 50% reduction in convulsive seizure frequency during the treatment period was about 43 or 49% in the CBD groups compared to 26 or 27% in the respective trials' placebo groups, which met statistical significance in the trial by Miller et al., but not Davinsky et al. Close to 2/3 of caregivers to participants who received CBD in each trial rated the participants' overall condition as slightly, much, or very much improved, compared to 34 or 42% of caregivers to placebo recipients. The 2 RCTs of Epidiolex for children or adults ages 2 to 55 with clinically confirmed Lennox-Gastaut syndrome, abbreviated LGS, were similarly designed to the trials for DS. Participants had treatment refractory seizures as indicated by an inadequate treatment response to at least 2 different ASDs and persistent seizures with at least 2 drop seizures per week during the 4-week baseline period. Drop seizures were defined as atonic, tonic, or tonic-clonic epileptic seizures that involved the entire body, trunk, or head, and that led to or could cause a fall, injury, or slumping in the chair. Seizures were tracked daily by the participants or their caregivers. In aggregate, by randomized therapy, the median number of drop seizures per month was between 71.4 and 86.9 at baseline. Participants were allowed to continue other anti-seizure therapies during the trial, including up to 4 ASDs if they had been taking the therapy for at least 4 weeks and their usage would remain stable. However, participants who had been taking the ASD felbamate for less than 1 year or who had received a corticotropin within the prior 6 months were excluded from participation. The trials by Thiel et al. And Davinsky et al. Both met their primary efficacy outcome, finding that CBD as Epidiolex 10 or 20 milligrams per kilogram per day for 14 weeks significantly reduced drop seizure frequency from baseline as compared to matched placebo. Most pre-specified key secondary efficacy outcomes also favored both CBD dosages over placebo. The proportion of participants achieving at least a 50% reduction in drop seizure frequency during the treatment period was between 36% and 44% in the CBD treatment groups compared to 24% or 14% in the respective trials placebo groups, which met statistical significance. A significantly greater percentage of participants or caregivers to participants who received either CBD dosage rated their overall condition as improved from baseline compared to the placebo recipients. An additional RCT evaluated the efficacy of Epidiolex for seizures in 224 children or adults ages 1 to 65 years old with confirmed clinical diagnosis of tuberous sclerosis complex, abbreviated TSC. Participants had medication-resistant epilepsy, were taking at least one ASD, and had at least 8 TSC-associated seizures over the 4-week baseline. TSC-associated seizures included focal seizures with or without impaired awareness, focal seizures evolving into bilateral motor seizures, or generalized tonic-clonic or atonic seizures. In aggregate by randomized therapy, the median number of TSC-associated seizures per month was between 54 and 61 at baseline. And like the trials in participants with DS or LGS, participants were allowed to continue stable usage of other anti-seizure therapies during the trial. However, participants were excluded if they had been taking the ASD felbamate for less than 1 year or if they were taking an oral mTOR inhibitor. And recent surgery for epilepsy was also exclusionary. While participants were randomized to CBD 25 milligrams per kilograms per day or 50 milligrams per kilograms per day, not all participants achieved or stayed at those doses during the trial. At the end of the 16-week treatment period, 87% and 53% of participants in the 25 milligram per kilogram and 50 milligram per kilogram groups respectively were receiving that target dose. The mean modal dosage in the 50 milligram per kilogram group was 36 milligrams per kilograms per day. Regardless, the percent reduction from baseline in TSC-associated seizures was significantly greater in both CBD treatment groups compared to placebo. The percentage of patients achieving at least a 50% reduction in seizures from baseline was numerically higher at 36% and 40% in the CBD groups compared to 22% with placebo, but no formal statistical test was reported. A greater proportion of participants or caregivers to participants in the CBD 25 milligram per kilogram and CBD 50 milligram per kilogram groups rated their overall condition as improved from baseline compared to the placebo group. However, this was not statistically significant in the higher CBD dosage group. Numerous types of adverse events, abbreviated AEs, were reported by 10% or more of participants in a particular CBD group and at an incidence 5% or greater than the respective trial's placebo group in each Epidiolex trial. Most AEs were gastrointestinal or neurologic in nature. Dose-related increases in hepatic transaminases were observed in each trial. Numerically, more patients receiving concomitant valproate or valproate and clobazam with Epidiolex had increases in hepatic transaminases compared to patients not taking valproate. Overall, most AEs were of mild or moderate severity. However, the incidence of serious AEs or withdrawals from the trial due to AEs tended to be greater among participants who received CBD compared to placebo, particularly at the studied CBD dosages of 20 milligrams per kilogram per day and higher. Open label extension trials in which all enrolled participants received Epidiolex followed those RCTs I just reviewed in patients with DS, LGS, and TSC, and they provide insight into the longer-term safety and effectiveness of adjunctive CBD therapy. These studies were excluded from our review because they lacked a control group, but I wanted to briefly mention them. At the time of these publications, not all participants had completed the extension trial, and data from the TSC trial extension is the least mature. Overall, these trials support long-term sustained reductions in seizures from baseline, up to about 48 weeks in patients with TSC or up to 156 weeks in patients with LGS or DS among the subset of patients who tolerated and were willing to continue adjunctive CBD treatment. However, the effectiveness could have been confounded by other factors, including that participants were allowed to add or change other anti-seizure therapies during these extension trials. The types of AEs during the long-term follow-up were generally like those observed in during the RCTs, but there were a notable amount of withdrawals due to AEs. 30% of withdrawals from the extension trial among people with LGS were due to AEs. 2 placebo-controlled RCTs evaluated the effect of Epidiolex 20 milligrams per kilogram per day at steady state on steady state exposure to other ASDs. Both trials enrolled adults with epilepsy of any type with at least one seizure in the prior 2 months. One trial assessed the effect of CBD on clobazam pharmacokinetics, enrolling participants taking clobazam 10 to 20 milligrams per day in combination with 2 or fewer other ASDs. Another trial assessed the effect of CBD on the pharmacokinetics of stiripentol or valproate. That trial included separate groups for patients taking stiripentol and valproate, each in combination with 2 or fewer ASDs. Using non-compartmental models, these trials calculated pharmacokinetic parameters reflecting exposure to the ASD or ASD metabolite, including the maximum observed plasma concentration, abbreviated Cmax, and the area under the plasma concentration versus time curve over the dosing interval, abbreviated AUC tau. Ratios of the geometric means before and after adding CBD and 90% confidence intervals for those ratios were calculated. If the bounds of the confidence interval were between 0.5 and 2, the investigators concluded that there was a lack of meaningful effect. Initiation of CBD with clobazam led to a significant 2 to 3-fold increase in exposure to clobazam's active metabolite and desmethylclobazam without significantly affecting clobazam levels. Modest increases in exposure to stiripentol and modest decreases in exposure to valproate or the valproate metabolite 4-ene-VPA when used with CBD were observed, but these changes were considered unlikely to be meaningful on average. Because there was significant interpatient variability in the changes in these parameters, it's possible that some patients could be more significantly affected. Generally, the safety profile of CBD in these trials was similar to what was observed in the other reviewed trials with Epidiolex. 2 RCTs evaluated the efficacy of non-Epidiolex CBD formulations in adults with focal epilepsy. The trial by Abadi et al. Was relatively small, including 27 participants with drug-resistant frontal lobe focal epilepsy. Participants in this trial were randomized to a liposomal formulation of CBD or placebo as an adjunct to other anti-seizure therapies. Participants were excluded if they were taking certain other ASDs, including clobazam. Notably, this trial suffered from poor reporting of some details, such as how frequently patients recorded their seizure frequency during the trial and at baseline. Additionally, it was noted that the mean baseline seizure frequency in the CBD group was over double that of the placebo group. O'Brien et al. Evaluated 2 dosages of CBD transdermal gel compared to placebo in adults with drug-resistant seizures and at least 3 observed seizures per month. Participants could continue stable use of other therapies, but concomitant use of certain ASDs, including clobazam, was exclusionary. The mean change in monthly seizure frequency at 8 weeks compared to baseline was significant in the liposomal CBD group, but not the placebo group. Adjunctive liposomal CBD therapy was not associated with significant changes in seizure severity, and liposomal CBD therapy was also associated with significant improvement in the patient-reported quality of life at 8 weeks, but not 4 weeks relative to baseline. Despite achieving plasma concentrations that overlapped with reported concentrations reached with oral CBD 5 to 10 milligrams per kilogram, transdermal CBD gel 195 or 395 milligrams failed to significantly reduce the monthly seizure rate over 12 weeks from baseline compared to placebo. Differences in secondary outcomes between treatment groups were also not significant. Although in the open-label, uncontrolled extension trial, during which participants were allowed to titrate up to the higher dose of 780 milligrams per day, some patients achieved and sustained a larger reduction in seizures relative to the RCT, suggesting that there might be a subset of adults with focal epilepsy who benefit from the therapy. Abadi et al. Reported little to no detail about the incidence of AEs relative to placebo, reporting only that there was no significant differences in the AEs between the CBD and placebo groups. The types of AEs reported by Abadi et al. Were somewhat similar to those that have been reported with Epidiolex, with the exception of a few AEs listed here. No information was reported about the changes in laboratory parameters like hepatic enzymes. Transdermal CBD was generally well tolerated by participants. The absolute incidence of treatment emergent AEs, AEs leading to treatment discontinuation, and serious AEs was slightly higher with CBD treatment compared to placebo. The most common AEs were headache, fatigue, nausea, and dryness at the application site. No significant increases in hepatic transaminases were observed after up to 18 months of exposure during the open label trial. The last included RCT evaluated the efficacy of cannabidivarin, abbreviated CBDV, oral solution compared to placebo among adults with focal epilepsy and persistent seizures despite trying 2 or more ASDs. Participants were required to have at least 1 seizure per week during the 4-week baseline period, and stable usage of other anti-seizure therapies was permitted during the trial. In aggregate, by randomized therapy, the median number of seizures per 28 days was about 18 in the CBDV group and 17 in the placebo group. CBDV oral solution 1,600 milligrams per day failed to significantly reduce patient-reported focal seizures from baseline to 8 weeks compared to placebo. The percentage of participants with at least a 50% reduction in focal seizures and the percentage of participants rating their condition as improved from baseline was similar between CBDV and placebo groups. Investigators reported that the placebo group's higher than expected response rate relative to historical RCTs is one possible reason that CBDV failed to separate significantly from placebo. While the overall incidence of treatment emergent AEs, serious AEs, and withdrawals due to AEs was numerically higher in the add-on CBDV group than in the placebo group, participants generally tolerated the CBDV oral solution, and the most common AEs associated with CBDV were diarrhea, somnolence, and upper abdominal pain. Diarrhea was the most common type of AE leading to treatment discontinuation. Significant increases in hepatic transaminases were observed in 3.7% of the CBDV treatment group compared to 1.2% of the placebo group. A risk of bias, abbreviated ROB assessment by a systematic review using the Cochrane Risk of Bias version 2 tool for randomized trials was available for 9 of the 11 included RCTs. The global ROB rating, accounting for scores in all individual domains, was considered low for 3 trials, unclear or with some concerns for 3 trials, and high for 3 trials. The systematic review did not report a lot of detail about their rationale for selecting a particular rating, but all 9 trials were considered to have a low risk of bias arising from the randomization process, deviations from intended interventions, or missing outcome data. And trials are rated to have a high risk of bias arising from measurement of the outcome and/or selection of the reported results. We did not perform a formal risk of bias assessment for the remaining 2 RCTs by Brody et al. And Abadi et al., but we noted that they both had potential bias concerns arising from measurement of the efficacy outcome and missing outcome data. Considering the types of cannabinoid-based formulations studied across the RCTs included generalizability of the body of the experimental trial evidence to medical cannabis formulations available to Utah patients with epilepsy remains uncertain. We are aware of expert opinion statements about the use of medical cannabis or cannabinoids to treat epilepsy from the Epilepsy Foundation that was published in 2019 and from the American Epilepsy Society that was last updated in 2022. It's unclear to what extent they considered evidence reviewed by this report or other sources. The Epilepsy Foundation suggested that medical cannabis or CBD oil could be considered for patients with uncontrolled seizures despite conventional therapies. However, they suggested that interested patients only consider the cannabis-based treatments after consultation with an epilepsy specialist to determine whether all other possible evidence-based treatments have been reasonably tried. The American Epilepsy Society reported that there's a lack of robust evidence for using cannabis-related therapies other than CBD to treat epilepsy. They called for more research in this area and encouraged people with epilepsy to work with their epilepsy specialist to explore and make informed decisions about treatment options. The current CRRB guidance document for the management of epilepsy with medical cannabis includes one formal graded conclusion, which states, with the exception of CBD/Epidiolex, there is insufficient evidence to support the conclusion that medical cannabis or cannabinoids other than CBD are effective or ineffective treatments for various types of epilepsy or seizure disorders. Informally, the guidance also summarizes some descriptive and/or observational evidence not addressed by this review and provides guidance about considerations for using medical cannabis treatment for adult and pediatric patients. Regarding potential updates to the formal recommendation, the board could elect to maintain the current recommendation or slightly modify it. The current recommendation generally reflects the body of experimental evidence in support of CBD oral solution as Epidiolex for the treatment of seizures among patients with DS, LGS, or TSC, and the minimal or lack of experimental controlled evidence for the use of cannabis or cannabinoid-based products to treat seizures in people with epilepsy. Keeping the recommendation as is could be beneficial as it's relatively straightforward. Yet, if desired, minor changes could be considered to make separate recommendations about Epidiolex versus other cannabis-related products, which would enable including more details than in the current formal statement. The CRRB should also consider reviewing the guidance document to ensure continued agreement with the non-graded recommendations and guidance. Notably, current guidance highlights some observational evidence excluded from this review. In section 5.1 of the written report, I noted some examples of uncontrolled single-arm clinical trials that evaluated the use of Epidiolex to treat some severe epilepsy conditions not represented in RCTs, as well as some studies of other non-Epidiolex products. The board may also consider adding a brief summary of RCTs that are not addressed by current guidance, as well as making some other minor updates about DDIs and dosing of CBD based on the most recent Epidiolex prescribing information. These are my references, and that concludes the presentation. Thank you for your time and attention as always, and I'm happy to address any questions that you have.
I see Taylor's got a few there. I know I've got some there in the chat.
I'll just raise the, one question. This is great, Lauren, as always. Thank you so much for putting so much into these. They're really wonderful. I was wondering if you, as you went through them, if you found any rationale for why, at least in some of the early studies that you presented, with Epidiolex in particular, why some, if they were taking other ASDs, those were okay to continue if they've been on them for like a year or something like that, but felbamate was almost always excluded, and then there were other kind of isolated examples of exclusion like corticotropin, and then there was one other one. I just wondered what was the rationale for including some but excluding others? Did you get any sense for why that is?
They didn't really explain in the articles, and so I could only hypothesize from my point of view as a non-specialist in epilepsy. I will say that felbamate, it's also used as it's like only recommended to be used after trying a bunch of other therapies. So kind of similar to CBD. But it also has a black box warning for hepatic failure. So given the hepatic concerns with CBD, maybe that was a reason. With the corticotropin, I know so some of these trials, or actually most of them were conducted, multinationally, many of them including patients in European countries. And in Europe, there's like a long-acting formulation of corticotropin. And so that 6-month timeframe maybe is related to that product.
Yeah.
But I don't know for sure. I'm just hypothesizing.
If I can add to Lauren's statement, I think I don't know for sure as well, not being involved in any of the trials, but I would have presumed it was also the liver, the potential for liver interactions with felbamate.
So just like a safety concern above all else.
That would
That
be
makes
my
sense.
supposition.
Yeah.
Lauren, do you know of all the patients that were withdrawn from the study because of adverse effects, how many of those were more like over sedation versus hepatotoxicity?
Off the top of my head, I do not know. I
I
can look
suppose it must
into
be in the
that.
details of all the papers
Yeah,
somewhere of how
I
many,
do
like,
include some more details about that in the written
Okay.
report for each separate trial, but like overarching all of them combined, I'd have to
okay.
look into that.
No, I was kind of wondering like some number had an increase of AST, but it wasn't enough to have the drug discontinued, and how many people actually having it stopped because
Yeah.
of some predefined threshold of that.
Yeah, I mean, I will say for if you look at the Epidiolex prescribing information, which of course has a warning about the hepatotoxicity, I think it says 1% of patients have like this really severe hepatotoxicity. So it's relatively rare if they're monitoring it and, managing it.
One other question, Lauren, and this might be kind of getting into it a little bit more than we need to, but you did mention at the beginning, which I think is really important, as the inclusion criteria to get into these trials wasn't really clear what their prior cannabis use was, or even CBD use was, what their patterns were coming into it. And I think that could be relevant. Could be relevant on who comes to the table for this trials in the to begin with, and could also be relevant in terms of like what the effectiveness of placebo or treatment is in it too, right? So, one way to maybe loosely get at that is like because cannabis policy is not the same universally. Some places it's much more restricted than others, and if these trial participants were recruited from different areas, I'm guessing in a RCT they did not look at geographic variation, but um, but it seems like maybe if we were concerned about something like that, if there was geographic variation in the studies, that might be one of the hypotheses that what their pre-exposure was coming in is different. But I'm guessing they didn't report on that. But if they did, I'm curious if you noticed that or not. So
I didn't notice anything about that specifically. Like I said, there was definitely a lot of geographic variation because they were enrolling people from even different countries. It's possible there are like separate publications addressing that, but I was just very focused on, kind of the
yeah.
primary.
Well, usually in RCTs, the idea is that you're accounting for all that, so you don't have to look at that variation.
Right.
If it was like a cohort study, you do.
Right.
But in this case, it's like, well, is it truly? But I guess we're arguing maybe it's not really an RCT if people could have, a different profile coming into this. And so, yeah.
Lauren, I have a couple questions. One, were there any other studies that looked at other other cannabinoids besides just CBD, or the one that you mentioned on CBDV? Were they all just sole pure CBD products like Epidiolex or cannabis based? I asked because I know of two patients. One was an adult, the other one was a child, who CBD was more effective when they added fractional amounts of THC. But I didn't see any studies that mentioned any kind of profile like a 20 to 1 or 25 to 1.
Yeah. Good question. I was focused on trying to find the highest quality evidence. I was focused on the
Yeah.
experimental controlled trials.
Yeah.
I am aware that there are other non-experimental studies out there, like
Yeah.
observational studies or even experimental studies that were uncontrolled. So they only had one treatment group that received the.
Yeah. And these were clinical cases, so I don't know if any studies were done, but
Yeah. So if you look at section 5.1 in the written report, I did try to give some examples of that, and I cited a systematic review that also looks at some of that. But none of the trials that I included and focused on included products like what you're
other products. Okay.
describing. Yeah.
Thanks.
Misty, any comments on
Yeah.
THC or other cannabinoids?
Russ, I'll add to your point that a lot of the evidence that we have for the minor cannabinoids obviously is preclinical, but there's also case reports. Unfortunately, they don't meet the criteria for inclusion in discussions like what we're having here.
Yeah.
But there are a variety with minor cannabinoids that show evidence supporting an entourage-like effect with some of the
Yeah.
minor cannabinoids.
I was just curious that
also,
there just seems to be no clinical studies, no random.
and that's a problem in the field.
Yeah.
There's a sad lack of controlled clinical trial into these. If you look at clinicaltrials.gov, a year ago when I last looked, there were a number of studies that were looking at medical cannabis. But if you go in more recently, some of those trials are no longer listed. So I don't know if they couldn't get the appropriate enrollment for their limitations, inclusion criteria. I don't really know what happened to some of those. A couple of things that I'll point out is, if you go back a little bit before the 2018 publication from the NIH, there are some older clinical trials that were very briefly and not really conclusively included in the 2018 guide, or discounted as weak evidence because they didn't do a full patient history. But I'm thinking about the Ing study from 1980. There's a Kuna study from 1980 and in 1990, Tremblay and Sherman. These are all small clinical trials that were done. I think it was the Kuna study actually had 298 placebo and 300 cannabis, if I'm not mistaken. It's been a while since I looked at them. But there is some older work that didn't meet the criteria because they didn't get adequate patient histories and past exposures, but they did show some evidence. But when the 2018 article came out, they were considered weak because of the design of the study. But it might be interesting to go back and have a closer look at those and see what they actually predicted. The only other thing that I'll point out is that in 2024, there was a new patent issued, a European patent issued, that cited some articles that I've not seen and I haven't been able to get access to because it's European. But it was from GW Pharma, and it's specifically for development of products that are CBDV, CBD combinations.
Right.
And evidence is obviously predominantly or exclusively preclinical, but in their justification for the patent, they list a lot of these older trials and work before these substances were made controlled. So it might be worth taking a deeper dig at some of these older studies.
Yeah, it's unfortunate they haven't looked at it. I know at least in the adult case, the individual had a 20% drop in seizures just by adding small amounts of THC to the CBD protocol. I mean, it's one case, but it seems like no one's picked up on that. Yeah.
Right. And we hear about that a lot from patient advocates. And unfortunately, it's very difficult to get those studies funded.
Yeah.
Lauren, could you bring up our current recommendations and sort of your proposed thing again? I wanted to chat about a couple things kind of on those points. And two things leading into that. One was like the remarkable amount of placebo effect in epilepsy studies of plenty of placebo patients with pretty massive reductions, though certainly not as much as the treatment arms, but virtually all of them, except for I think the CBDV study, the placebo groups had like 20 and 30% seizure reduction, which I guess goes to the difficulty of interpreting single patient case reports of you changed something and then you had a seizure reduction, and was that true or not, or is that just the natural history of epilepsy of ebbs and flows and ups and downs? I don't think that says anything to our evidence there, but just kind of a comment of when there's such a strong placebo effect, that making sure we have a good level of evidence that we're assessing, which we certainly did. So we currently have that. I was wondering about, I was just looking through a couple dispensary websites and what's available, and it seems like on the few that I pulled up while we're here, they have a single oral CBD product available for sale that doesn't include THC, and they're like 20 to 30 milligram edibles, which at 10 per kilo is a lot of edibles to eat to consume a sufficient CBD dose from those medical products available at the dispensaries. And so are patients treating their epilepsy with CBD in Utah just getting these from the corner vape shop or online and not our medical products, or what's happening?
It's over-the-counter CBD products, hemp-based typically.
And I suppose people may come look to us for recommendations anyway, even if people aren't using the normal QMP and medical card program, they may still be looking to us for evidence. So I think that's worthwhile, but I think just kind of interesting that there's not CBD available from these. And I see on the January data, there are 622 patients in the state with epilepsy as their condition. And I'm wondering what they are using and why someone would need a medical card to treat their epilepsy if the CBD products aren't even available in the medical program.
Yeah, I know in one case they were using Charlotte's Web, which is available over the counter online out of Colorado. I don't know what others are using.
And then I guess my next point was, then Lauren, can you go to your next slide on some of the proposed things? Because my idea was, do we break it out specifically of Epidiolex? Yes. Others, no, but then maybe specifically call out THC or other things rather than saying other CBD formulations, of saying, hey, you might be wondering about THC, like you just brought up, Russ. And we could say there is insufficient evidence to support or refute that THC is beneficial for seizures, and maybe including something specific like that, because that seems like a common question a provider might come up with of, oh, wait, I know about CBD, but what about THC? And I guess we kind of say that things that aren't that don't have evidence, but we could specifically call out THC, since that might be a main question people have.
Yeah.
I agree, Mike.
Yeah, I think if you look at clinical evidence, you can say that. I mean, there's just, it just there aren't any studies.
Yeah, and I would just follow up on that, Mike and Russ. What patients are doing are just getting formulation with THC. They're not following the guidelines that suggest CBD only. They're just getting what they can get from the pharmacy.
Yeah.
And like Russ said, a lot of them find benefit. So and I see in the chat someone mentioned that too, that they're getting CBD with THC, and that's what they're using. Our job is to try to prove what a lot of patients are experiencing to be useful. Our job is to try to figure out why and prove it, and we haven't done so yet.
Yeah.
So I like the idea of separating this out so that we can at least leave that door open and say, well, there's insufficient evidence. And I don't know what else you put on the next page, Lauren, about having leaving the door open for more studies to suggest what what we can do with CBD and THC for epilepsy. I don't know, but I like the idea of separating the recommendations out so that we can leave it open for future modifications once we find more evidence.
I think that's good. We keep our, CBD, Epidiolex, other things that aren't Epidiolex, THC, and other cannabinoids, maybe have a few of those broken down so people can get the answer to the question that they're looking for in there.
So broaden that insufficient evidence.
Yeah, maybe either even as a single statement where we just spell out the specific ones, or have a THC statement, a CBDV statement, since it's been specifically studied, or however once we break it out. I guess that can be up to all of us as we actually make the revisions, but I think having some separate
Okay.
statements so people can find those kind of high level pieces of what is there. I know patients are getting this, whether they get it through the medical cannabis program or not, is the cost point and whatever else is, I suppose not our program's main goal, because normally we say we can't find things in the medical cannabis program that are THC of, you know, a balance one or whatever else. And if the CBD is out there and they don't have to get the card, that's fine. We want people to have the information they need to make at least the best informed decision that they can. More discussion points on this.
There is a 2023 article that was published in Neuropediatrics entitled Clinical Outcome Data of Children Treated with Cannabis-Based Medicinal Products for Treatment-Resistant Epilepsy, an analysis from the UK Medical Cannabis Registry that I want to point out goes into some of the smaller clinical trials that were done in Europe, including many of the studies that were published in Israeli populations, where a lot of this work originated from the McCollum Lab and others. There is a Israeli case series where they looked at a subgroup of children with CBD and THC preparations ranging in dose from 120 milligrams per mils, and they saw a significant, a greater than 50% seizure reduction in these treatment-resistant epilepsy kids when a small amount of THC was added into the preparation.
Yeah.
So I think that's driving a lot of the hemp-derived. I think if you go to Nanette Berezny's comment in the chat, there is small clinical trials coming out of Europe and Israel that are getting at the combinations. They're actually doing somewhat of a better job than we are here in the United States at moving that forward on a small scale.
Yeah, I agree, Misty.
Yeah, so the question becomes then, you said there right there, there's substantial evidence that high dose CBD works, right? But you can't get high dose CBD in our dispensaries. It's much cheaper and easier to get a combination product with THC. So the question is, does the addition of the THC amplify the CBD effects enough to compensate for the lower dose of CBD? Like that's the pharmacologic question, right? Is that what we are seeing? And can we prove that?
At least that's in part my experience with people I've spoken with through my teaching, but I don't have any clinical evidence to support that, you know.
Because I'm in agreement, Russ. That's what I see. I see that the addition of THC amplifies the effects of CBD, so you don't need the high dose.
Right. Which
if there's a
mitigates some of
combo
the
product.
Yeah, it mitigates some of the increase in liver enzyme, hepatic enzyme level as well.
But we've got to show that.
And if you look into Ethan Russo's work, he actually shows better efficacy with slightly lower doses of cannabidiol versus the higher doses where you start getting the opposite effects.
Right.
And he, from conversations that I've had with him, he also cites the improved actions when THC is on board.
So it's great that we have the substantial evidence that high dose CBD works. That's like step one. Now we've got to, step two is to figure out why the combo products and what ratio works and at what population. And like Taylor said, Taylor brought up an important point, which I've taught a lot about clinical work, is patient selection is the most important part. My whole job, I feel like my whole job is figuring out who needs medicine, who doesn't. Like not just cannabis, but everything I do is selecting patients who needs treatment and who doesn't need treatment.
Yeah.
That's so important. And so for these studies, patient selection, histories are really important. And to leave those out, like Misty said, that it just ruins a lot of the research. If you don't know who these patients are and where they're coming from and what their background is, then it changes. It can change a lot. So
yeah. which I find interesting. They don't do that in the studies, or at least they don't report it. I mean, if someone comes to me and says, I'd like some advice on using cannabis, I take a history. That's the first thing I do is take a history, you know.
Absolutely. Okay, so I'm sorry to interrupt you, Mike. We need to go back to those recommendations and look at them. Like, do we want to change, according to Lauren's suggestion, option 2? And I don't mean to derail the objective here.
No, I think this is good. It's much easier to do this while we're all here talking with each other instead of trying to ping it back and forth over email. So I think as much as we can hammer out right now, it's great. Do we need that? Bring that slide back up.
Yeah, let's look at it again.
Sure, sorry. Oh, a second. All right.
Lauren, I guess pharmacist question. We're talking about other CBD formulations than Epidiolex. Is there anything fancy about Epidiolex as it's formulated that would make us think it's substantially different besides it's been approved and it's pure and it's just CBD and there's no THC?
Well, it contains sesame oil. It contains a small amount of alcohol. I mean, it's a unique product, I guess.
Yeah. There's nothing that makes it in a different release or sustained
Yeah.
release or something else that's necessarily
Not
different.
that I'm
It's a
aware of.
liquid instead of a gummy, I guess.
Yeah,
But
it's an
whatever
oil
that's worth.
solution.
Well, and it's standardized, whereas your CBD formulations, whether pharmacy or over the counter, they're going to vary from manufacturer to manufacturer. You know, they just do. But the fact we don't have an offering in a liquid form, that we're offering, you know, edibles with often, you know, can you imagine trying to have someone take 20 edibles and they've got, you know, 2 or 3 grams of sugar each on top of the fact that it's a low dose.
Matt, what was your point here of what we want to go with? It sounds like that first one under option 2 we're in agreement with, which is all right,
Yeah.
substantial evidence for the high dose for
Yep.
Epidiolex, and then
Yep.
maybe it's for the other pieces or
I like that. So I like the first paragraph. There's substantial evidence that high-dose CBD solution could be an adjunct therapy. And like we had alluded to earlier, like Russ said, I mean, cannabis therapy is an adjunct almost all the time. It has very few primary indications, but as an adjunct, it's useful for a lot of things. So I like that point. The second point, insufficient evidence for CBD formulations. As it stands now, we have to say that there's insufficient evidence. But is there any kind of follow-up statement, Lauren, that you could say, or that we could indicate why there's insufficient evidence, or you know, just to kind of tie those 2 points together to say, well, a lot of people find usefulness for this, but there's insufficient evidence as it stands now. But
In other words, you're asking for detail there, Matt?
I think
or
it's
some kind of
important to point
reference.
out- I think it's important to point out it's insufficient evidence based on RCTs and ECTs.
Yeah. Yeah.
Yeah.
That's what
Yeah.
Lauren's getting at with the NASM categories.
Yeah. I like that, Misty. Yeah. I agree.
So I think if you were not limited, which we have agreed from day one, we are limited to RCTs and ECTs. But I think, you know, I think the frustration, at least what I hear from a lot of advocates, is that we're not considering these other smaller trials. So I don't think it would take anything away from it to acknowledge that there are non-RCT ECT studies that show promising trends, however you want to word it, but you're lacking the randomized or experimental controlled trials to support them. where
Yep,
you're
that's
just
perfect, Misty.
acknowledging that they exist.
Yeah.
Yep.
Because
That
there,
kind of leaves the door open a little bit. So I like the way Misty put it. It's
Yeah.
and I would even go one step farther and encourage, you know, ongoing research into, you know, gaining more clinical and translational data.
Are we at a
Because-
point where we can take this offline for some
Yep.
edits with all these thoughts?
Yep.
I feel like I have to nominate Misty to be our lead, maybe editor on this document if you accept. Or always it's a group effort, but I think
Yeah.
if we have one or two people like we did with Melissa and Russ for the PTSD, of someone else of one or two people to kind of take the lead on revising our things for epilepsy, it's helpful to get everyone started.
Yeah.
I'll second that motion.
I'll be happy to review whatever gets up. How about that? It might be a while if you want me to take the lead on it, just because of other commitments at the moment. But if somebody wants to take the first crack at it, I'm happy to edit. I can turn that around pretty quickly.
I think we'd be operating similar timeline with what we usually do, which is hopefully have revisions that are brought back by our next meeting, which I guess is to be determined the exact date of that, but our second quarter of this year. So have at least a few months for whoever would be willing to tackle it for sure. Is that enough
Thanks
time
again,
to
Lauren,
take a
for
lead,
doing.
Misty, or are you feeling that like if we're in this 2-3 months range, that's gonna be on the back burner for you for a while, or?
I think for at least the next month, it's going to be on the back burner for me. But I think if all we're doing is, if we're leaning towards the second option, where we are expanding our recommendation and we just want to add an additional statement that outside of the NASM RCT, ECT trials, where we're acknowledging the smaller studies with an additional statement, then that would be reasonable.
Yeah.
Russ, maybe you and I could come up
Yeah.
with a statement that we think is appropriate.
I'm happy to help with that.
That's-
Sure.
I think that's reasonable.
Okay.
Maybe we can talk offline.
Yeah.
Right. Well, we're doing pretty decent on time. Any more comments on epilepsy presentation or revision to the documents now before we move on?
I just wanted to thank Lauren. She did a tremendous job because it's a really since 2018, there's been an explosion of work in this area. Not necessarily in terms of studies that we would include based on our limited scope, but I know she had to probably trudge through a lot before she got to what meet our criteria.
Yeah, thank you very much, Lauren. As always, huge lift to sort through all the data. Okay, then I'd say we can move on and let Rich tell us about what the legislators have cooking for us on cannabis amendments. Seen a few things in the news.
Yes, yeah, I'm happy to do that. As I think you all know, the legislative session began on January 21st. It ends on Friday, March 7th. And so we're right in the middle right now. And I'll just focus my comments on those policy changes impacting DHHS and patients and medical providers and in this committee. So the first piece of legislation I thought I'd share, and I think the most significant is HB 203. and they're on the third substitute of that. It's titled Cannabis Amendments. It's proposed by Representative Daley Provo. And there's a lot of amendments this bill makes, but I'm going to focus just on 6 of those as we talk about it. This particular bill has passed through the House of Representatives, and it is now in the Senate Rules Committee. And that's where typically bills go when they're waiting to be assigned to a different committee. So we should see that be assigned to a different committee soon. But one of the major parts of that legislation is that it requires that when a product is sold at a medical cannabis pharmacy, that it include with it a patient product information insert. But this patient product information insert wouldn't have to be in paper. It could be on a QR code, or it could just be a link that's available in an email that's sent to the patient, but it would be required to happen upon every transaction. And so one role that DHHS has is developing, in consultation with the University of Utah Center for Medical Cannabis Research, the patient product inserts that would be available to each patient who purchases a medical cannabis product. And the insert must include information such as how to use the product, some side effects, dosing, contraindications, safe storage, information on when the product should not be used. And also we're able to require any other information the department deems appropriate in consultation with the processing facility that created the product. So that is a piece of legislation that I think will guide patients to learn more about the products that they're consuming, and we'll see where that goes. And then also there is some legislation that impacts processor targeted marketing. Cannabis processors under this proposal would be allowed to engage in targeted marketing under certain conditions, and they could create a website with information about their products. There'd have to be an age gate where you have to be over a certain age in order to access that information. And it would also allow including or posting of a certificate of analysis from an independent lab. So patients would be able to track down that information about the products that they may be interested in. And this just helps cannabis processors share information about the products that they're selling to the retail medical cannabis pharmacies. And it could create some pressure for medical cannabis pharmacies to sell certain products that patients are really interested in, and we'll see. Also, the bill creates a medical cannabis ombudsman, and this ombudsman position would be within DHHS, and the legislation sets forth a few of the duties that they would have. One would be that they would consult with DHHS and Department of Ag and Food regarding administrative rules related to medical cannabis. And they wouldn't have any authority over those rules. They would just consult with DHHS and UDAF on the rules. A prior version of the bill did give them some authority, but the most current version of the bill, the sub 3, does not. It just allows them to consult with DHHS and UDAF. One critical role of the ombudsman would be to contract with a nonprofit entity to provide monthly $150 vouchers to medical cannabis pharmacies as part of a patient voucher program. And so this is for medical cannabis card holders who have held their medical cannabis cards, who had their medical cannabis cards and are also enrolled in Medicaid or Medicare. So one of those eligibilities would need to, an enrollment would need to be in place in order for them to qualify for this voucher. And the vouchers are funded through the funds that we collect at the Center for Medical Cannabis from transaction fees and from medical cannabis card application fees. So also the Medical Cannabis Ombudsman, one of their duties is to hear all of the appeals for administrative action taken by Department of Ag and Food. So if there's a cultivator or a processor or a medical cannabis pharmacy that is disciplined, they could decide to appeal that decision made by the Department of Ag, and the ombudsman would hear that appeal and consider the evidence and then come with a decision, and whatever that decision is would be the final decision about that administrative action. Also, an additional duty that this ombudsman would have is to issue 2 additional medical cannabis pharmacy licenses beyond the 15 currently issued. So that would mean we'd have a total of 17. 1 license would be selected by the ombudsman before January 2026, and the other would be selected before January 2027. And there's some requirements that the entity that those licenses are issued to could not have any ownership interest in a current medical cannabis pharmacy or processor or cultivator license. And also the licensing fees, because they're required to be located in medically underserved areas, the licensing fees for these 2 locations and the other locations that are located in medically underserved areas already, they would have a lower licensing fee. That, in fact, they would be 50% of everybody else's licensing fees as far as pharmacies go. So that just makes it easier for a medical cannabis pharmacy located in an underserved area to be able to operate, lowers their expenses. And then one final duty of the ombudsman is just to train about their role and duties to private citizens in civic groups, governmental entities like law enforcement, and other interested parties across the state. So that gives you a high level understanding of HB 203. Then there's some other, that's related to the ombudsman, but an additional amendment in the legislation that this would make is it would sunset the Cannabis Research Review Board, this board. And so the duty is currently performed by the Cannabis Research Review Board, if this bill passes, would be performed by the University of Utah Center for Medical Cannabis Research. So the review of cannabis research literature and education of medical providers and in the public about medical research advances, those duties would be taken on by DHHS and with help from the University of Utah Center for Medical Cannabis Research. So that certainly has impact on the board. And then also the Medical Cannabis Policy Advisory Board membership change. This amendment, what it requires is that the board include 1 representative from the University of Utah Center for Medical Cannabis Research appointed by the U of U. And then also there was an amendment to the bill that was made in this 3rd sub that sets a recommending medical provider proximity to a medical cannabis pharmacy limit. So a pharmacy under this provision would not allow cannot allow a recommending medical provider to recommend medical cannabis within 500 feet of the medical cannabis pharmacy's property line. So there's a few instances of that across the state, and the sponsor of this bill wanted to address that. So that is something that would impact recommending medical providers of medical cannabis throughout the state. Okay, so that is HB 203 sub 3. But another bill is Senate Bill 64. They're on the first substitute of that bill right now. It's titled Medical Cannabis Amendments, sponsored by Senator Evan Vickers. And this bill requires that employees of medical providers with access to the electronic verification system, the EVS, they'd be required to complete a 1-hour course on health information privacy once every 2 years. So currently, there are some clinics that are new clinics, and some of them don't do training that others do. And so there was this thought that, hey, we need to make sure that the employees that work with medical providers, who some of them may not have worked in other health settings, we need to make sure that they are, if they have access to the electronic verification system, which gives them access to a lot of private health information about patients, that they have at least a 1-hour course on health information privacy. A lot of clinics do a great job of this already, but there's some that may not. And so this was an amendment that was proposed in the bill. There's some other housekeeping items in that SB 64 related to Department of Agriculture and Food and DHHS, but that was the one I think you'd be interested in hearing about the most. There's also House Bill 357, that's titled Medical Cannabis Modifications. Representative Ray Ward is sponsoring that, and that right now is with the House Rules Committee, still in the House. This removes the need for medical providers to register with DHHS and to become qualified medical providers in order to recommend medical cannabis to over 15 patients. So it enables any MD, DO, PA, APRN, or podiatrist to recommend medical cannabis to up to 1.5% of the current number of medical cannabis cardholders, which right now is about 1,400. And so there would no longer be the terms qualified medical provider and limited medical provider. Any medical provider that meets those requirements of being an MD, DO, PA, APRN, or podiatrist that has a controlled substance license could go ahead and recommend to up to 1,400 patients. And so there's currently about 960 qualified medical providers. So all of them obviously would be able to continue to recommend medical cannabis. We just wouldn't designate them as QMPs. They would be recommending medical providers. And then medical providers would no longer be required to complete 4 hours of CE specific to medical cannabis. But DHHS can still approve CE courses and make them available online to medical providers who want to learn more about medical cannabis. And so the courses that we currently have links to on our website, we continue to link to them. And 2 private companies have courses we've approved, and then Intermountain has a course, and so does University of Utah. Those would continue to be available to medical providers who want to learn more, but they're just not required. But when they complete those courses could count toward their DOPL CE requirement. So, and there's no requirement for medical providers to renew their registration with DHHS. So the QMPs that are in the program, they're in our system, but there would be no requirement that they renew in the future. They just have an account, they're in our system, and then they can recommend medical cannabis to up to 1,400 patients. And we're at about 94,000 active medical cannabis patient card holders right now. And as that total number of active patient card holders grows, so does the patient limit. So we'll adjust that in April, and it'll be somewhere beyond 1,400, because that patient limit is always required to be 1.5% of the current number of active medical cannabis card holders. Another bill is HB 343, Cannabis Production Amendments. Representative Paul Cutler is sponsoring that legislation, and Department of Ag and Food under this bill is required to establish odor control standards for cannabis production establishments. And that includes cultivators and processors. And this will require that Ag purchase some devices to be able to monitor the establishments to ensure they're complying with whatever those odor control standards are. So that's what that bill does. One thing I did not mention about HB 357 and the changes related to medical providers and QMPs and no longer having QMPs is that legislation in the current version, it does not become effective until July 1st. So that gives DHHS some time to make changes to software and also to educate medical providers about changes to that part of the program. And then just a bill I found out about this morning was SB 248, Controlled Substance Amendments. This is a bill sponsored by Senator Collimore, and it was published yesterday, and it's waiting for introduction to the Senate. But if you remember, there was a bill last legislative session, or maybe 2 sessions ago, I think it was in 2023, that created a very limited way that a medical health system could allow for a patient to pilot with psilocybin or MDMA, and in a very controlled setting under a health system that was either Intermountain, it had to be a nonprofit, which is pretty much Intermountain, or it had to be a health system affiliated with an accredited university like University of Utah Health System. So that's what happened in the past. And then this SB 248, what it does is it just expands it a little bit. It makes it so the setting could be with just a palliative care provider and a psychiatrist. It adds those 2 settings beyond the major health systems of Intermountain or University of Utah Health System. And so also it provides for the automatic rescheduling of a certain type of psilocybin if it's rescheduled by the federal government. So that bill just became public as of yesterday, and it was just introduced to the Senate. And that's SB 248, Controlled Substance Amendments, sponsored by Senator Collimore. Okay, so I know that was a lot. Any questions about any of that legislation?
Can you clarify the proposal from Senator Ward? You said that was approved, or that's undergoing review in the Rules Committee?
Representative Ward, his bill was HB 357, Substitute 1, and that is with the House Rules Committee.
Okay.
It has not been approved by the House.
Okay.
And that's where it's starting.
Because I imagine there's significant, as Michelle pointed out from the UMA, but I'm sure others as well will have concerns about the removal of the educational requirements for QMPs.
Right, yeah, there could be some concerns out there, and they'll have an ability to reach out to Representative Ward either online or at the committee meeting when it's heard. Yeah. Other questions or comments?
I've got a few, Rich. So nice to hear about some of the information going to patients when they pick something up. That brings things more in line with like a regular pharmacy of here's some counseling or information on your medication. But then going backwards with removing education requirements because people aren't getting these otherwise. They're not getting it in med school or PA school or or other things. And again, disappointed that the legislature fails to consult with the experts before making these decisions. And I'm happy to say that publicly and on the record that they did not ask our board of what should happen before a provider is allowed to do this. And then, but also making it so it's not just a one-stop shop where you got the QMP office and the dispensary in one thing, but then liberating. So it's like lots of people doing opposite things, it feels like, on the cannabis landscape that are kind of moving in different directions. I guess the main thing for the board to discuss here is that sunset date would be effective July 1 this year of the CRRB.
Let's see.
It's HB
Yes.
203, yeah.
Yeah, that's correct.
Maybe Mike, like you suggest, I think Ray Ward is a family doctor, is he not? Isn't he a provider?
Ray Ward is a family doctor.
Yeah. So I'm guessing he's trying to remove obstacles to access, right? I think that's probably the nidus of this bill. But like suggested, I agree with you all. Education is really important, and it's not part of curriculum in medical school or residency. The only thing that they get is part of your DEA renewal. There is a section now on cannabis. It's not robust, but there is a section of education on cannabis with your DEA license renewal. And I guess the suggestion is that your knowledge of pathophysiology in school and that DEA renewal is enough. And I think that's arguable.
Yeah,
So
I would agree.
I'm not liking that.
Yeah. Well, my patients have told me, or students have told me, the QMP program has been somewhat of a block in getting into the program and staying in. But I think education is critical. I mean, that's what I do. I teach. So,
I appreciate the dilemma. We're trying to improve access.
Yeah.
And the QMP has, you arguably might say, has limited access. Patients have limited access to providers for guidance. But then removing the education, I don't know. It's a hard dilemma. I appreciate the dilemma.
I think the analogous thing is like the X waiver for buprenorphine for opioid use disorder was removed, but that came with a one-time 8-hour training or something else that has now been mandated into lots of residency programs around substance use disorder and opioid prescribing. And if it came with, well, everyone who's got a controlled substance license in the state of Utah gets this required cannabis training, and so now everyone's basically an automatic QMP. That'd be one thing. But it sounds like it's maybe not.
There must be a suitable compromise where we can keep the education component in some fashion and drop the limited QMP. I'm not sure what that looks like legally, but that's just my feeling. Maybe the thinking is that providers who don't have an education won't recommend. I don't know. That's
it's
maybe
just like, I guess, anything else in medicine, that if it's not your specialty, you're going to say, well, you need to go talk to somebody else about that, whether it's cardiology or cannabis, right? That if you're not comfortable, you're going to point someone to another source.
Yeah. So Michelle says that's what he's saying. That would be my inclination. That's what he's thinking.
But I will also say that it may open the door for misinformation.
Exactly.
I guess I would like to talk a little bit about, the sunsetting piece. We have, I don't know if Valerie and Larit are here to weigh in on our board switching over to the Center for Medical Cannabis at the U. I know we kind of had this in mind that this could be coming, and we planned out that we would kind of try to wrap things up and not put too much on the board's plate so we could approve all the things we're going to approve and then be done, so we wouldn't leave outstanding business when we weren't formally existing anymore or something, or leave an uncompleted project in CMCR's hands. So I guess it's totally up in the air to Valerie and Jerry and Larit of what the new thing would look like, but I'd be open for any discussion from the current board or Valerie or otherwise of what needs to happen in the coming months to switch things over.
Hi, Mike. Yeah, thank you for bringing this up. I didn't want to jump in because you guys had so much on the docket, so I'm glad you were able to get to it. But Larit and I have been spending some time just kind of reviewing the bylaws and kind of looking at what transfers over and what makes sense to expand upon. we also did meet with Rich and discuss a little bit about how we might move this forward. But I do think that there would be some value in if it is possible for us to actually have a meeting that is specific to with all of you to talk about what this transition looks like. And also potentially discuss those board members who would also maybe like to come and serve on any type of research committee as we're building this. So I know we still need to formalize an overall process, but I think the main questions we have at this time would be, um, w- what are specific expectations, particularly with Rich, and what do we know we need to get back to the public, so we can start building that out. Who on the committee would like to continue on the committee and kind of get that piece and component going. We also have met with Lauren a few times to take a look at how we can approach the literature reviews, and Larit has been in the process of that, and kind of establishing that. So we're in a formulation stage, but I think the main thing that would be the most important for this board is consider if it's something you would like to continue doing, and please let me know, and if please literally just send me an email and then we can go from there and start building out. I think what we'll end up doing is having more specific expertise, like expert research committees, based on the indication that we're looking at. Um, it's a lot for you guys to look at every single indication when that's not your expertise. So our hope is that if we can start building, maybe, 4 to 5 people in one group, but multiple research committees based on that indication, we might be able to get a little bit more granular, in providing, information back and be able to do it more frequently. So if that's of interest, please reach out to me, and then, over time we'll put together a transition plan, and kind of find some time to go through it. I don't know if Larit or Jerry are on. I don't think so, but if anybody has any additional questions, or, oh, there you are, Larit. Do you want to add anything? Did I miss anything?
No, I think you got it. I think right now what we want to know is who wants to still be involved, because we're still building the infrastructure. So it's going to look very similar. We want your input and all that. So it's an ongoing conversation.
Valerie, if we want, and Loretta, if we want to have all of the board present, then it probably needs to be in an official public meeting, and we could make a significant time period for more discussion at our April meeting. If we want to do some offline things with a few people, or request that any of the board members interested let Valerie know that they'd like to continue, that's good. But if we want to have a big group discussion, we should probably just make it an agenda item for the April meeting.
I will
and
leave.
just- Go
I will
ahead, go
leave
ahead.
that. I will leave that to you guys, because I don't want to take people's time if they're not interested in doing it. So, but also, as I do think that it would be important also for you guys to feel that we're making enough time to transition with you. So, please, if you guys feel that it's appropriate for us to, kind of set that as an agenda item for the next meeting, like Larit and I will be here. And we can let Jerry know, so he might be able to make some time. But if your preference as a group, especially now that you know you're transitioning, if there are more important things that you do need to get done that, need to occur in the public sphere, then for those people who do want to participate, they can reach out, and I can, kind of work with you guys to find a time that works best for everybody.
Misty will have you go, and then we'll see if we can cram some few things in our last couple minutes after that.
I just had a real quick comment, Valerie, since education is one of the part of the mission of the CMCR. I think it might be a good time also, perhaps with Jerry's help, to kind of build a bridge of communication with the School of Medicine. I can speak to the College of Pharmacy's education on medical cannabis because I teach those courses, but I think it really would be an improvement to get some sort of calibration as to how much of their curriculum, if any, is spent on medical cannabis. And even if it is somehow providing what's taught in the other colleges, I mean, I'm happy to offer my lectures. Russ also is a really well-respected educator on medical cannabis. Anything that we can do to promote education for our future clinicians, it will improve everybody's outcome long term. So I've had difficulty individually getting a straight answer as to how much of their classes, particularly their pharmacology, if any, and that's what I'm worried about, is spent talking about medical cannabis, because nobody seems to know, and that is concerning. So if there's anything I can do to help with that, I just don't have the contacts in the School of Medicine to be able to find those answers, but perhaps you can even with Jerry's help.
Yeah, I've actually in the past had a meeting with a prior, they're now retired, but they were concerned about the ability for for basically we don't have very many QMPs at the U, and that was part of their frustration as a geriatric patient. So she reached out to me specifically to discuss this. And we talked a little bit, and she does actually have a contact within the training department within the School of Medicine. So this has been kind of in the back, kind of percolating, and has been something that has definitely been brought up of how much training goes into kind of the overall, view for the School of Medicine, but also is there anything that we can do to begin to support more of the practitioners within the U to potentially serve as QMPs and to support any type of cross training. So we can definitely prioritize it, Misty, as something to discuss, and
Great.
start kind of thinking about that on a broader scale.
Let's put all
Anything I
that on
can
our
do, I'll
next
let you know.
agenda so we can get through our last couple agenda items, and
Yeah.
we'll talk in April about all those pieces and beyond. So be thinking about all those things. I guess, Sarah, we can give you a little bit of time for some safety updates if there's something to share in a minute or two, and then any public comments that are out there beyond what we've heard already.
Yeah, it can be pretty quick. Just some updates that we are doing. We redid or just like redesigned a little bit the medical patient assessment checklist. We felt like it was a lot of text, so we just made it a little more engaging and better for mobile in case providers are using this on their phone or tablet or whatever it may be. So just updated how it looks to be a little more engaging and easier to follow. I don't know if this was launched the last time we met, but we launched the important information about medical cannabis webpage. I'm going to do the same thing where we redesign it a little bit so that the content's easier to follow and more broken up. But something that patients can use to know the risks and know how to use it safely. And this is sent out to patients when they get their card as well. And then just one bigger update is that we are redoing our website to be more intuitive and user-friendly. So that's going to be a big change, but we just want things to flow better and for people to be able to find the information they're looking for a little easier. So those are all the updates from me.
Okay, that was speedy. Thanks, Sarah. With our last little bit, we can even take another minute or two if we have any public comment, and I guess we can put up that little thing there. People can raise their hand and we can call on you and have you identify yourself. I don't think we have 2 minutes for every single person here, but if we do have some public comment, we want to make sure we hear you guys.
While people get queued up for that, I wanted to make a little correction about an effective date on HB 203. That becomes effective on May 7th. So I think I may have, there's a separate bill, HB 357, that becomes effective in July. That's the one that changes the QMP. But HB 203, that legislation become the one that sunsets the CRRB, that becomes effective on May 7th.
May 7th, not July then, huh?
Yeah.
Okay. I guess our last meeting's in April then. Okay, I see Michelle with your hand up. I'll let you have your
Thank
turn.
you. So Michelle McComber with the Utah Medical Association. We have had concerns on all of the bills, honestly, in the different areas. We have been commenting on them and meeting with legislators, but the education, we agree, the big part is that they're not receiving it in a medical school or any of the training schools, right? And so we do think that educational piece is important. And when we met with Ray Ward, he actually met with our legislative committee. He said that the problem is that there's 90,000 cards, there's 45,000 that are actually using them. And so he wants to lower the barriers. We said we think there's probably another reason. One, it doesn't, it may not work for the patient after they tried it. They may be going somewhere else to get whatever product they wanted across state lines. And then we are concerned with high THC content products in the pharmacies, which we are now finding out is happening when it wasn't supposed to be happening. So that really is all the comments that I have. Thank you.
Thanks, Michelle. I agree with you on all those, and I think those have long been our concerns too, of having educated people to inform patients and have the right products available based on the evidence that's out there has been the board's kind of long-standing trouble. So
Yeah.
we're all, I think, kind of right there with you on those same issues.
Agreed.
Anyone else, Nanette, or anyone else that was there that I've missed or wants to put their hand up? And any other board comments as well before we adjourn?
Yeah. If there's no more community comments, I'd like to say one thing, but
Go
any
for us.
okay.
I don't see any other hands
So
up.
first of all, I mean, this isn't our last meeting. Apparently we have at least one more. First of all, this committee has been great. Everyone here is, from my perspective, got their heart into this. They're doing it from the best and highest good. So thank you all for that. If I don't get a chance to say that another time. And I agree, even to Michelle's point, I think I'd like to see a paradigm shift in the cannabis industry and in the science. We aren't addressing a balanced approach to the cannabis medicine. And I don't want to go into a lot of detail about that, but I think we're focusing too much on two cannabinoids. We're not looking at the whole family of the plant and the entire protocol. And so my hope is that we can help create a paradigm shift as this board gets sunset and maybe moves some members over to the university, that we can look at a more holistic approach, look at the plant as a entire profile and not just focus on two cannabinoids and both have become too dominant in both the science and in the law. So that's my hope. I'd like to see a more balanced approach generally.
I agree wholeheartedly with that.
I'll take a quick second. I second what Russ has said, and back to the education piece. As we consider how to improve education in the medical school or the training schools, it's got to start with the physiology. People might be intimidated by the pharmacology of it, or feel like it's agenda driven to try to increase prescriptions of it. But really, it's how do you call yourself a doctor and not know the physiology? So I think that's where the education starts, is in the basic science of the neuroanatomy and physiology. And so we've got to make that happen at all the training levels. Anyway, I've also appreciated everyone on this board. It's been very, very, very good. I just wondered about the symposium in January. Was that a success? I wasn't able to attend, but was that symposium? I didn't hear anything about it.
I believe it was.
I thought it went great.
Yeah, we got really great feedback across the board, and we actually plan to ensure that you guys, for those of you who may need to serve in during any of the legislative sessions, we hope to move that out so you guys can join us more readily. And in the future, I know like Russ and Dr. McKiff, you guys are out in southern Utah, so we'll start to make some plans to potentially have some virtual options too, just so that you guys can pop in and attend as well.
Good.
Awesome.
And the keynote speakers were excellent. I felt like Dr. Pakula did a great job, and same with Ryan Vandry, very knowledgeable, two of the really experts on their topics in the US, and it was great to help the group learn from them, and then good participation from those from the Colorado universities as well, in addition to University of Utah, and of course Misty was able to share some of her thoughts with us as well, which was good.
Thank you.
And good participation from the industry. We had representatives there from, I think, at least 4 of the companies in Utah that participate in the program. And it was good to have them there as well. And some patient participation was good. Good to have their input too.
Sounds like a success. I hope it will be repeated.
Yeah.
All right, guys. Well, thank you everyone for today. As always, we've got lots to talk about. We'll do some revisions to the epilepsy document, do some planning for our next session. And I think we won't be trying to tackle a new subject in one single remaining meeting. So we will wrap up with epilepsy and definitely get that done by the end of this, and be thinking about ideas for the transition, and let me and Valerie and whoever else know about your either thoughts going forward, whether you do or don't want to participate, how you would change things. And I guess with that, I would take a motion to adjourn.
Move to adjourn.
Okay, I think we'll call this officially adjourned, 7 minutes late. Thank you everyone for coming, for Lauren for your contributions, everyone's good comments on things, our public and everyone else who's attending, Rich for keeping on top of all of those different bills that are in process and all that you're juggling right now. And yeah, thanks everybody.
Thank
Thank
you.
you.
Thank you.
Have a good one.
Bye guys.